So, as I had said it, today we are going to speak about beta blockers. Beta blockers, why beta blockers? It's not only among the most commonly used drugs, which is not only used by cardiologists, but even by the other specialists as well. And even if you go to any of the countries as well, from the richest to the rich to the poorest or the poor countries as well, they do use it. A lot of generic examples are there in beta blockers as well. There are some of those non-generic drugs as well, and so they do tend to have a lot of applications for such kind of patients as well. So this is the reason why we are trying to think. I'll try to describe my talk in all these subheadings, in fact. So way back in 1964, in fact, a famous scientist called as James Black, he was one of the ones who was able to make one of the first beta blockers, which was called as propranolol. Okay, and later on, of course, there were a lot of clinical trials which were able to show its effectiveness as well. That it is a wonderful drug for different conditions like the primary hypertension and also not even stroke as well, and a lot of other conditions as well. So the main question comes is, what are those beta blockers? Why do we call them like this? Because they are the ones which acts on these receptors, which is called as the beta 1, beta 2, otherwise some of them which are not even selective. So beta 1, so the important question comes is, beta 1 receptors are most commonly found in the heart. Beta 2 are the ones which is most commonly found in lungs, okay? And and there are some of those beta blockers as well which are non-selective in the sense, so it may be causing some other side effects as well. So for example, they will be having some antihypertensive effect. They will also be having pulmonary and peripheral effects as well. So beta blocker action, so for example, if there's a drug which is going to have more of a beta 1 selective action, so if it will be acting on the heart, right? So it will be causing is several side effects like bradycardia, negative inotropic action, and also will cause a fall in the blood pressure. However, if a beta blocker, especially like something like a beta 2 receptive one is going to be there, so it is going to be acting on the as I had said it, it is going to be acting even on the lungs as well. So as I said it, beta 2 receptors are present in the lungs, in fact. So they, as I had said it, on the basis of the what type of receptors these drugs are acting, you can try to divide them into cardioselective, non-cardioselective. So similarly in the cardioselective as well, as I said it, beta 1, no, beta 1, beta 2 in fact. And even on the other side as well, if it is beta 1, again you can further divide into internal sympathomimetic action activity, otherwise the non ISA activities. Okay, even for the non beta 1, beta 2 as well, similarly you can divide. So the selective beta 1 blockers with internal sympathomimetic action will be acebutol, celiprolol, and the ones without will include those normal ones like atenolol, bisoprolol, esmolol, metoprolol, or nebivolol. Okay. Similarly, when you are talking about those non-cardioselective, okay, non-cardioselective with internal sympathomimetic actions will be including pindolol, oxpranolol, or cartenolol. Otherwise, the ones without will include the propranolol, nodolol, or even sotalol as well, or even carvedilol. Um, I will try to explain in the coming few slides as well what are the selective indications for these drugs on an overall basis. So, what happens is whenever we are trying to think about the application of these adrenergic blockers, so what will happen is if you will try to recall about the pathophysiology of the different diseases, these catecholaminergic surges has a quite a lot important role, not just in arrhythmias. In fact, even for the modulation of the heart rate, the blood pressure, and even the occurrence of a coronary artery disease. And when we are talking about the pumping action of the heart as well, so it is very important, in fact. So that is how it tends to modulate not only the myocardial oxygen requirement of the heart, but can also further potentiate for ischemia and also for the arrhythmias or further leading to the certain cardiac death as well for such kind of patients. So, why is the molecular structure of these drugs is important? The molecular structure is important because whenever we are trying to see what are those possible alternatives. For example, if you are thinking of using acebutol, but you don't have acebutol, so what is will be the other alternative you can think of, which resembles pretty closely. So if you, that's the reason why molecular structure is quite a lot important. So for example, acebutol and esmolol, they look pretty similar and they can be modified to replace or help each other as well. Similarly, if you'll try to look nebivolol, it looks quite a lot different when you try to compare with the acebutol. So even its morphological action on any of the cells or the organ system in which it is being used, it is going to be different, right? Now, being in cardiology, we are interested. What about the indications? So, why or when can we advise someone to start on this drug? So, one of the most common things is those arrhythmias. Will include sinus tachycardia, of course, the sign then even when you are especially trying to control the rate, if someone is having ischemia or the heart failure. Similarly, if someone is having an atrial fibrillation, in atrial fibrillation, why do you think of using it? You're not only trying to reduce the rate, but you may also be able to restore the sinus rhythm as well. You may also combine it with digoxin or the verapamil or diltiazem as well. So similarly, if someone is having an atrial flutter, a beta blocker is going to be helpful to reduce the rate, and also there's antiarrhythmic action as well with this drug. So similarly for the atrial tachycardias as well, or if someone has already undergone a cardioversion for the atrial or ventricular arrhythmia, so if you want to maintain the sinus rhythm as well, so it's very effective. Other than these actions as well, so if someone is having premature ventricular complexes or ventricular tachycardia as well, you may even combine them with quinidine, otherwise with the other drugs as well. So it is very much helpful to prevent the recurrence in cases of the sympathomimetic uh, mediated VPCs, and it also tends to decrease the incidence of ventricular fibrillation and also the sudden cardiac death, even after post myocardial infarction as well. Okay, arrhythmias, yes. Now we are able to know that, okay, there's a good indication for this. But what about the other cardiac indications? So there are quite a lot of cardiac indications in the sense. So what will happen is the most common ones. So something like the ischemic heart disease. Ischemic heart disease, we know someone can be having a stable angina, unstable angina, even after myocardial infarction, or if there's a silent ischemias as well, or someone is just having hypertension, or with the ventricular hypertrophy, or sometimes what will happen is even in conditions like the pheochromocytomas. So, pheochromocytomas, it is one of those endocrine disorders. It does have indication. So, someone is on heart failure. So, in the class 1 to 3, but of course not in class 4. Can anyone tell why not in class 4 heart failure patients we should not use beta blockers? Please use the chat box. Please use the chat box if you'd like to answer this question. I have said it, heart failure should be used. Okay, low ejection fraction, wonderful. Okay. So someone has already said it. And others, what do you think? What could be the possible reason? So what may happen is it may worsen the patient, in fact. So that is one of the reasons. Similarly, if someone is having a prolonged QT interval or aortic dissection as well, or the patients with valvular heart disease, otherwise if there's tachycardia in pregnancy as well. So uh, those are the other reasons as well. So if someone is having a higher chances of perioperative mortality, again, it has a selective indication for that. And there are a lot of other non-cardiac indications as well. Can anyone recall what are those non-cardiac indications where beta blockers can be used? So cardiac indications we did discuss, right? So right now we can use it for that. Okay. What about those non-cardiac indications? Okay, thyrotoxicosis, wonderful. Uh-huh, good one. Good, good. I'm really happy to see that today's our session is being attended by a lot of smart and very smart students. As you all we're already telling, so someone is having anxiety, or someone is complaining of essential tremors, otherwise alcohol withdrawal as well, or Batter's syndrome, so which is associated with the juxtaglomerular hyperplasia, or someone with complaints of glaucoma, migraine prophylaxis, or narcolepsy, thyrotoxicosis, even tetanus as well, it tends to have a big role. So, about its mechanism, I had already said it. It tends to have, by acting on those beta receptors, it does tend to cause an effect. So, what is the basic mechanism? So, what is happening is if there is a ischemic myocardium, it is going to reduce the myocardial consumption, lower the heart rate, the blood pressure, and also the myocardial contractility as well. And this is how it tends to cause the augmentation of the coronary blood flow and increase in the diastolic perfusion time by reducing the heart rate. So, a concept which should be there in our clear should in our mind is diastole is the time when there's coronary perfusion happening. So whenever there is an increased heart rate, the diastolic time tends to reduce, and that is one of the reasons why ischemia can potentiate. So what happens is by decreasing the heart rate, you are trying to increase the diastolic time, diastolic perfusion time, and that is why lowering the heart rate is very important in ischemic patients or even heart failure patients as well. And not only it decreases the microvascular damage, in fact, it also tends to stabilize the cell and lysosomal membranes. And this is the reason how it also inhibits the platelet aggregation and also decrease the chances of myocardial infarction. And as I had already said it, the microvascular effects, which you can see especially in patients who are there on the congestive heart failure, it tends to upregulation of the beta receptors and also improves the ability of the non-adrenergic sympathetic nerves to synthesize the norepinephrine. And the adverse maladaptation mechanism which starts happening especially in the chronic heart failure patients, it is going to help those patients as well, and it is further, for example, going to decrease the stimulation of other vasoconstrictive system, including the ras, vasopressin, and even endothelin as well. And as I had already said it, for example, it tends to have a good antiarrhythmic effect by raising the ventricular fibrillation threshold as well. And of course, it does protect against the catecholamine induced hypokalemia as well. So, even on the other side as well, it tends to have multiple actions. Multiple actions. So, for example, when you will talk about some of them like Carvedilol, it has been shown to have not only vasodilatory effect but also a antioxidant effect as well. In fact, on a molecular basis, it has been shown to cause modulation of the post receptor inhibitory G proteins as well, which tends to further increase the natriuretic peptide production. So, which is indeed beneficial, especially when we are trying to think for the heart failure patients as well. And that is one of the other reasons as well for heart failure patients. If you are aware, one of the important biochemical parameters is pro BNP levels. That's the reason why you try to do it, isn't it? So there are a lot of those drugs which is being used. So I already commented about the internal sympathomimetic action. So it is sometimes important for us as well to be able to understand, considering the various plasma half-life, how much is the dosage we should be giving and how often we need to give. So if you try to look carefully, for example, for drugs like Pindolol, the half-life is only 4 hours. So that's why what will happen is if you're trying to give them to the patient, you should give them more often, isn't it? However, if you are trying to look for drugs like Nadolol, the plasma half-life is pretty long, 20 to 24 hours. So then the thing is, you can give always a very low dose and even less often as well to the patients. And whenever you're trying to think for the therapeutic levels as well, so that's why you should be careful. Like, is it a lipid soluble drug or not? Similarly, the plasma protein binding is very much important. Whenever you are trying to think on the parameters of how much of the drug which is being given is going to be available in the blood levels of the patient. Okay. Um, so, how many of you are aware of these drugs, which is shown in the slides right now? Atenolol, bisoprolol, carvedilol, metoprolol, noodolol. Noodolol. Does anyone remember? What is it being used for actually? Yeah. Okay, noodolol is being used for what? So, what is noodolol used for?
Second generation.
What second generation? I said, what is the clinical indication for using noodolol? Please use the chat box. Everyone, keep your microphone muted. Please use the chat box. Hypertension, okay. And so, what is the best indication for noodle? Okay, angina, hypertension. Okay, I'll tell you. So, what happens is, especially for out of hospital cardiac arrest or catecholinergic VT, noodle is said to be one of the drug of choice because it it has a wonderful association for those kind of patients, and especially if someone is having arrhythmias as well. Yes, it can be considered, and it has a very long half life. So even if you give like 40 or 80 mgs as well once daily dose, that should be pretty good. Similarly, see why in this slide why we are suggesting about the maximum suggested dose. So, for example, what happens if there is a patient who comes, and if you are considering bisoprolol. So, I'm practicing currently in UK. Okay, so in England, bisoprolol is one of the most commonly used drug, which we really quite a lot often we use it. So you can start them on even lower dosages as well. So I do see where my colleagues they start the patient on like 1.25 mg as well. So 5 mg, yes, it is written, but always you can always start them on as low as possible, and then slowly up titrate. So, for example, for bisoprolol, you start from around 1.25 mg. You keep on seeing what are those potential side effects which you can come across, and as I said, you can keep on up titrating them, and you can go up to even like 20 mg as well. Okay. Now, similarly about like sotalol. Sotalol, you can again start like 40 mg. 80 mg pills are there. You can take around. Someone's microphone is on. Yeah, now it is fine.
Hello,
Again,
sir. Excuse me, sir. Voice is not clear. It's breaking.
because someone's microphone was on, so there was a noise which I could hear. Please keep your microphones mute. This is a request, I would say, everyone. So, now coming to the sotalol, which I was telling. So, one can be started on 40 or 80 mg as well, and you can go up to around 320 mg as well. So, sotalol is another wonderful drug in the sense not only it is a beta blocker. So, can anyone recall what group of antiarrhythmic it belongs to? Sorry. What group of antiarrhythmic drug classification by von Wuggen Singh? Von Wuggen, you all are aware, but the real classification name is von Wuggen Singh. So there was a Indian guy as well who was associated with the classification, but his name has not been promoted. What group of drug does it belong to? If yes, okay, yep, wonderful. So in von Wuggen Singh classification, the class 1 belongs to sodium channel blockers, right? The class 2 and the class 2 belongs to which group of drugs? So what is the class 2 group of classification in antiarrhythmic drugs? Right. Wonderful. Dr. Basnet. So the class 2 classification includes beta blockers. The class 3 belongs to potassium channel blockers. And the class 4 belongs to calcium channel blockers. So this classification is very important. So sotalol definitely it is a beta blocker as well, but it also has potassium channel blocking action as well. So that's the reason it is a wonderful antiarrhythmic drug which can be used not only for atrial arrhythmias but also for the ventricular arrhythmias as well. Okay, carvedilol, as I had said, it tends to have a vasodilatory action and also antioxidant action as well. So that is one of the other reasons as well why it is preferred quite a lot in the anti-heart failure drugs. So a lot of times I do get asked questions. So, for example, if someone is doing the medicine and all, uh, that why UK or these Western countries like they tend to prefer bisoprolol so often whenever they are prescribing any beta blockers. I'll try to show you some of the examples. So, as I was telling you, it's not only important like start from a lower dosage as low as possible and then start titrating. The titration, how do you titrate? So, for example, the first dosage is always as low as possible. Then, in the third week, you can almost um, double the dosage. Then, by the sixth week, you can again increase it further. And the finally, in the end, the final dosage, you can do it like this. So, up titration of a drug, especially drugs like beta blocker or ACE or ARB inhibitors as well, it is a very important thing. Now, similarly, what happens is um, these beta blockers are there. So, what happens is you can further classify them on the basis of non selective. versus cardioselective and vasodilatory agents. So, as I was telling you, so that's how I introduce you to propranolol, right? So, propranolol is a wonderful drug, especially we tend to reserve them for thyrotoxicosis patients and all. Other than thyrotoxicosis, what are those other conditions in which we try to reserve them, propranolol? Anyone recalls them? Migraine, good. Even in kids as well. Yeah, anxiety, wonderful, great, very nice. So in anxiety disorders as well, we can use it, and it is being used and it is advocated in wonderful drugs. Um, like last week itself, one of the patient I would say, so the patient was so much dependent on propranolol, so much so that like this gentleman had been taking it for a decade, and so we were thinking of switching him over from propranolol to beta blocker, considering his arrhythmias history. And this guy was so much dependent, he was like, no, I'm not ready to take any other beta blocker other than propranolol. So sometimes it can even happen like that. Uh, Now about the Nodolol. So Nodolol, I had already said it as well. It's a wonderful drug, but one of the best indications, especially for Nodolol, is the catecholinergic VTs. So a lot of times those out of hospital cardiac arrests, if you're sure about the mechanism and all, so a lot of those Brugada patients, otherwise genetically morphed arrhythmia patients and all can have this, and Nodolol is a great drug. I would really suggest you should not forget at all, especially something like sotalol. Sotalol, as I had already said it, due to its additional potassium channel blocking action, it's a great drug, especially in antiarrhythmias as well. It's being used and it has got really good action. Okay, acebutol. Acebutol has a very cardioselective action. But another benefit with acebutol, they try to see. Okay, can anyone recall how is the effect of beta blockers, especially on the lipid profile of a patient? Okay, good, good, and yes, wonderful. So it tends to, on an overall basis, what happens is it tends to have a adverse effect. It's not so favorable effect on the beta blockers. So acebutol is one of the drugs which has been shown, and pindolol as well, not to have much of effect. And this is one of the other reasons as well. Still, the quest for finding an ideal beta blocker has been going on, and due to which a lot of different beta blockers they keep on coming in the market as well. But the thing is, you should be aware how do they compare with each other, especially when you are thinking of the side effects, or how are they comparing with each other. So as I had said it, for example, if there's a patient for which you want to control the diastolic filling of the coronary arteries, so then you will use these beta blockers. As I So why are we trying to compare the beta blocker calcium antagonists and the oral nitrate? So a lot of times their action may be a bit similar. Beta blockers will also decrease the heart rate. Calcium channel blockers will also decrease the heart rate. Okay, so both will definitely cause relief of angina. However, if you're trying to see for the prevention of the cardiac death, beta blocker, yes. Calcium channel blockers, definitely no. Like that. So even when you try to think for the subendocardial ischemia as well, so beta blockers definitely has a proven role. However, the calcium channel blockers, no, not at all. So oral nitrates as well. Oral nitrates will be able to decrease the heart rate. Okay, but when you try to see on the parameters of the angina pectoris or even VF or the sudden cardiac death, no. Unfortunately, there's not much of role for that. So this one is a wonderful chart in which you can compare all the effects of the different pharmacological property of the beta adrenergic blockers. So how? Propranolol compares to timolol, metoprolol, nodalol, atenolol, carvedilol, bisoprolol, acebutol, or even versus sotalol as well. So on the various parameters of the relative cardioselectivity, otherwise the potential ratio, or the lipid solubility or bioavailability as well. So this slide is very, very important for everyone, I would say. So in this, especially these drugs are the clinically relevant, the most commonly used beta blockers. Most commonly used ones: atenolol, metoprolol, carvedilol, and bisoprolol. So if you look carefully, of course, beta selectivity is highest for bisoprolol. Okay. Similarly, if you will try to see for the heart failure patients as well, there is of course good evidence for bisoprolol, carvedilol, and also for the metoprolol. However, for atenolol, there's not much of evidence. Okay, and the bisoprolol, the good thing is, yes, you just need to give once in 24 hours, so that should be pretty much good. However, whenever you're trying to give someone a carvedilol, you are aware. So what is going to happen is, as I had said, it is not only it has an antioxidant action, but also a potential vasodilatory action as well. So that's why a lot of people may prefer carvedilol as well whenever they are trying to give. And similarly for metoprolol, yes, metoprolol has a good role in the hypertensive or otherwise even the heart failure or MI patients as well. Okay, and it is a lipophilic drug. So it's a great drug, but really nice. And similarly, although for heart failure patients and all, try if someone is having with diabetes, better to avoid carvedilol. Uh, we all are curious people, right? We start to think, okay, I brought your choices, for example, to less than four. Okay, that which one should be used for what. If you guys have to use for different indications, which will be the best beta blocker? Okay, what are the common side effects you all come across whenever you are using? Okay, metoprolol. Okay, someone says metoprolol is the best beta blocker for hypertension, for example. Okay, bisoprolol. So I already showed you how do they compare on the different parameters over here. Any adverse reactions which you all have come across whenever you use these most commonly used drugs, most commonly used beta blockers? Anyone would like to share? Please use the chat box. Hypoglycemia. High heart rate. Okay, cough. Cough, it has a different mechanism actually. Normally, cough is a uh, side effect secondary to ACE inhibitors due to its accumulation of bradykinin. Cough, rather than cough, it causes the spasm of the bronchial tree actually. Bradycardia, yes, yes. Congestion of lungs, yes, that can happen. Please use the chat box, I would suggest. Okay. Asthma, yeah. So it doesn't cause asthma, but it precipitates the attack of asthma. Yeah. Bradycardia, wonderful. Asthma. What else? Good. Peripheral artery disease. So this is another great slide in the sense, if you'll try to look carefully, what happens is a lot of times you will come across those, yeah, complete heart block can also happen as well. So whenever you are using these drugs, so if you're using them in a pregnant lady, so a lot of the times the question comes is, can she do the breastfeeding? So what happens is only for pindolol, if you look carefully, Yeah, it can be used, but with caution. Otherwise, for most of them, what is happening is it will be getting excreted in the breast milk, and of course, it can cause problems as well in the kid or the infant as well. So that's why you have to be a bit careful whenever you are using them in the pregnant ladies. Now, the important thing is like, how about those patients if someone creatinine clearance is pretty low, and if someone has been over taken an overdose of that medicine, can it be helpful? Can we help them? Can we do a hemodialysis? So what happens is if someone has taken bisoprolol, unfortunately hemodialysis may not be possible. Okay, and then what happens is when you're thinking for a patient, um, yeah, if there's someone's creatinine clearance is really really low, still, for example, for drugs like esmolol or metoprolol, you need not worry at all. However, if you have been using bisoprolol, so if someone is on really lower creatinine clearance, you should always use it with a minimum dose, and you can always up titrate it. Okay, but bisoprolol, the problem is it is non-dialysable, so you can't do the hemodialysis even if you want to affect. We all are aware that if we have someone from African, Caribbean origin, ethnic origin, so what kind of antihypertensive shall we be preferring for such ones? So normally we should prefer is calcium channel blockers, something like amlodipine and all. Okay, so even for beta blockers as well, there are such minor variations in the sense propranolols may be uh, needed in higher dosage for such patients. Okay, and similarly, if metoprolol is being used, especially in Chinese patients, what has been observed is lower dosage of metoprolol is required in the Chinese. Okay, similarly, carvedilol can be preferred for the blacks in heart failure. Okay, so I already gave you the concept of beta 1 blockers, beta 2 receptors, otherwise even beta 3 ones as well. So beta ones are the ones, as I had said it, which are mostly there in those, mostly in the heart. They may be also seen in the kidney or the adipose tissue as well. So uh, by acting or selectively blocking those receptors in the heart, you can get the positive inotropic effect, the chronotropic effect, and also the cellular growth or the hypertrophy as well. So it does have a wonderful action, but similarly, you should be able to know what are its contradictory drugs as well. Okay, so what happens is if you're thinking about the beta 2 blockers, okay, so whenever you are trying to give them any drugs, so you should start also thinking about the glucogenolysis or gluconeogenesis as well, because that is going to affect all those things, and that's how that is one of the reasons as well you try to avoid these drugs in those diabetic patients. Okay, so not only it affects the various mechanism, what may happen is the hypoglycemic effects, the symptoms of hypoglycemia may be hidden as well. So if it is going to be hidden, so what is going to happen is if someone is having hypoglycemic episodes, you will not be able to know at all that this person is having those symptoms at all. So this is the reason why we have to know about how much is an example of beta blocker is selective for the beta 1, is it more selective for the beta 2, or how can we help those patients. So like other group of drugs, beta blockers also does have good drug interactions as well. So what you try to do is you should know the interactions. So because you're going to give beta blockers with the other group of drugs as well, and so for example, what will happen is if there's an alcoholic who's already taking it, however, you are giving them a lipid soluble agent, so something like a bisoprolol, you may have to increase the dosage, right? Similarly, if there is a patient who has been taking cimetidine, okay, so you have to be really careful that if you're trying to combine them with the cimetidine, it's better to avoid such patients. Similarly, if someone is taking a calcium channel blocker, so for a calcium channel blocker, you have to be careful because it can potentiate the effect of hypotension. Okay. Similarly, if someone is on digitalis as well, so what may happen is you may increase the chances of AV blocks for such patients. Okay, so that's why it is very important. Similarly, if if you are using them with the ergot alkaloids, so you should observe those patients. So if there's any hypertension episodes or peripheral artery hyperperfusion, so those things you must rule them out as well. So that is why it is very, very important. So this is another mega chart, I would say. It contains a lot of information for you, those drugs and how about the absorption, the bioavailability, and the dose dependent bioavailability as well, and what are the different concentrations which you are trying to achieve for these group of drugs as well. Okay, so the possible interactions as well for some of those drugs can be quite a lot important, as I was already telling you. So for example, if there is a patient on amiodarone and the patient is also taking digoxin, so what is the possible precaution would you like to do for a patient? So I'll repeat the question for you. If there's a patient on amiodarone and also on digoxin, what will you like to do? Okay, otherwise I'll give you another clinical situation as well. A patient is on ivabradine, right? And for the chest pain, you're already giving that patient also antidepressant drug. Okay, still the chest pain carries on. So you are starting the patient also on nicorandil. Okay, still the chest pain carries on and all. Now you are thinking of adding a ranolazine. So you have added. What is the side effect you are going to predispose that patient to? So two questions I'm asking. So the last question, okay, let's go for the last one. Okay, QT prolongation. Wonderful. Very nice. I'm really happy. That's very smart answer. So for example, so it has been shown that ivabradine, especially whenever it is being given with ranolazine, those patients can be prolonged, especially with antipsychotic drugs, they may increase the chances of QT prolongation. So you need to be very, very careful. Okay. So my other question was, so what about my other question? If the patient is on digoxin already, okay, you're trying to control the atrial fibrillation, ventricular rate, and you start them on digoxin, how are you going to, what you should be looking out for actually? Okay, I'll try to give one more scenario as well. If a patient is on digoxin, but the renal functions are compromised, what are you going to do? Increase, decrease, or no effect? Good. I can see some of the responses. So what happens is, whenever you are going to give a patient on digoxin start amiodarone, you should try to give a lower dosage, at least by 50%. Because if you give them together, it can potentiate the effect and it may cause problems for the patient. So that is the reason you should, whenever you're trying to put them together, try to be a little bit extra careful. Not just that, similarly, if there's a patient on, um, if a renal compromised patient is there for which renal functions are not so good, and you're trying to start them on digoxin, you have to be really careful. You're going to predispose such patients for digitalis toxicity. So this is the reason why I'm trying to show you so many slides, for example, for the pharmacological interactions and all, and these problems can happen. Please use the chat box if there are any questions. Otherwise, at the end of the session as well, I'll take some more questions. So now coming to those selective agents. So about the selective sotalol, I already said it. Wonderful drug for atrial and ventricular arrhythmias. It tends to also have the selective potassium channel action as well. And but you have to be careful. When are you using it? How you're using it? As I had said it, because it can also cause side effects. Side effects like sinus bradycardia. Otherwise, blockages can happen. QT prolongation can happen as well. Similarly, I had already said it about the beta blocker for the dyslipidemias. They do not increase the cholesterol levels in most of the people, but some of them can cause this. So what happens is nebivolol, otherwise even carvedilol as well, it has been shown to less effectively affect especially those cholesterol levels. And yeah, a lot of people, there is newer research as well which has shown that if someone is drinking like up to 5 cups of coffee daily, it can in fact even increase the blood cholesterol levels as well. About the nebivolol, so nebivolol is a newer drug. It's an awesome drug. It has a like almost 3.5 times selectivity of the beta 1 receptors. In fact, it's so if you come across asthmatics patients and you must still think of using beta blockers, then you can think of nebivolol. It's a great drug. Okay. How about acebutol? So acebutol is another again awesome drug, not only for acute myocardial infarction patients, but also for the atrial and ventricular arrhythmias as well. You can use it, and but the problem is like if again you come across those asthma or COPD patients as well, you must avoid such kind of patients. So this is again I'm trying to do it in a reverse way. Reverse way, for example, is if there's a heart failure patient or MI patient or arrhythmia patient, you must use beta blockers. However, for the other conditions, you can think about it. Okay, you may use it. So in the metabolic syndrome, hypertension, especially in the initial choice, or if there is a patient with stable angina or even the acute coronary syndrome as well, you may use it. It's no longer, for example, it's no longer a rule. For example, if there's a patient of MI that you must use a beta blocker. If the heart rate is really high, then you can consider the usage of beta blocker. So again, I'm trying to re-emphasize about